much, Naveen, and thank you, Nisha and Anuja, for working hard that every Monday 6:30 we should start in time. And thank you everyone for joining, almost more than 100 people. So this topic, when I got interventional pain management in palliative care setting, so although we do a lot of things, but I was a little nervous that what to say in 40 minutes and what not to say in 40 minutes, so that the message should go in a right way. So I just thought that exactly what should I tell, what exactly people wants to know. So it was in my mind, a lot of thought process were coming, and almost I have spent 5 days together and is wasted 5-6 papers that where should I start. And then suddenly I realized that I should ask people that what exactly they want to know. So I requested one of my resident to send a survey, and we made the questions of this survey. And although not many people have participated, but at least 56 people have participated, and I think 56 is a good number. 56 palliative care physicians. What exactly the survey, the aim of the survey was to find out the present knowledge and concern about interventional pain management techniques in cancer patients amongst palliative care physicians. So what exactly people are thinking and what are their concerns? We did this survey, and I will start with these findings of this survey. Do you have any experience in interventional pain management? So you can see that maximum people have observed. Many people have performed under supervision, and only 12.5% have performed independently, and almost 21% they have no experience. Then do you think that there is any role of interventional procedure? Again, they said that it should be considered. Almost 48.2 means like early interventional procedure. Needed in advanced stage, almost 32 point, means like 50% of people, they think that intervention should be in early stage, and there are people those who are not very sure. So I think a few percentage of people, and for them this will be a good this thing, that how it is important for us. Then next was the, do you think the integration of pain and palliative care is beneficial? And you can see that it's a huge response, and almost more than 95 people think that integration of pain and palliative care is beneficial. And this is the focus of our this thing, that how we can integrate pain and palliative care. We think that there is a need of integration, but whether we are really working in this direction, this is what I want to say. And then there is what according to the biggest palliative physicians apprehension with the use of interventional pain management, why they are so apprehensive. So again, this is very important, that fear of side effects and fear of failure of procedure. I think these were the two important things, and there are very brave people in this group also. 56, 7.1 think there is no fear, means they are having good knowledge of interventional pain procedures. Then the last question was, what seems to be the biggest hindrance in use of pain intervention? When you think that pain and palliative care should be integrated, what is preventing you? So we can see that lack of training, lack of infrastructure, lack of integration of pain and palliative care. These are three important things which we understand that these are the things which really prevent this. And most of the people, almost 75 people out of 56, they have said that lack of training, infrastructure, and lack of integration of pain and palliative care is the biggest hindrance. And there are few people those who think that there is individual factors are responsible. So why, after doing this survey, I thought that my talk in next 35 minutes should be which we should cover in this topic is, when should we do intervention first, because we are not very sure that it is step 4 or it throughout. When should we not do intervention? Common intervention, what are the common intervention? I will not go into the detail of common intervention because there is no time, but definitely there will be an opportunity for everyone. If they want, they can learn. What are the evidence? Whatever we are talking, whether there are any evidence. What can we do to improve coordination between pain and palliative care physician? And how can we create integrated pain and palliative care programs? So this is what my talk is. So first thing is, when should we do intervention? So we all know that cancer pain is very, very complex. And most of the time, majority of the patients, they get very good pain relief with WHO letter and basically pharmacological medicine, step 1, step 2, step 3. But there are certain group of it is a whether this is a very minor group, but definitely it's a major impact on the cancer patients that they don't get pain relief at all. So interventional pain definitely will depend on your patient selection and the patient assessment, that how you have selected your patient. It's not that all the patient need intervention, but there are certain group of patient is in, although there are many theories that it should be the last resort when all pharmacological intervention is failed. But now it is not like this. Although again there are hardly any very positive evidence that whether it should be throughout the WHO letter or whether it should be fourth step. But we all know that if pain is localized, if your selection of patient is good, his morale is good, you have explained the procedure to the patient very well, then if pain is localized, definitely based on the dermatome, nerve block is going to be helpful. Even in the diffuse pain, because most of the time cancer pain is a diffuse pain, but major component limited to a dermatome, definitely nerve block will be useful. Then there is a very good category where frequent episode of breakthrough pain is coming. For example, a case of CA tongue patient is good pain, having good pain relief throughout the time when he is not moving his tongue, or when he is not chewing, or when he is not swallowing, or when he is not talking or laughing. But as soon as he is doing some activity orally, means like whether laughing, chewing, swallowing, he is having pain. So this is a pain which we can relieve with intervention. Cancer survivor with a longer life expectancy. If a patient is cancer survivor, I will give you an example. Give example of all these in my subsequent talk. Cancer survivor with longer life expectancy is you get a patient, definitely put that patient and try to put that patient on some kind of intervention rather than putting that patient on medication. And effective oral analgesia. Oral analgesics are working well, but adverse side effects, patient is having intolerable side effect, then there is a need to so clear that this is the group when we should think of intervention. A palliative care physician should think of intervention in, basically I have searched almost 10 articles, and these are the most important indication when we should think that patient should go for intervention. Now there are certain contraindication we should not do. What is certain contraindication? Absolute contraindication. The patient is refusing. Patient psychological status is not good at all. Basically, life expectancy also will govern, but again, if patient is refusing straight away, we cannot do. Local or systemic infection where you want to give a block and there is infection, we will not go. Uncorrected coagulopathy, lack of technical expertise is again an absolute contraindication. If you're in your team, there is no one who understands that how to give local nerve block, definitely initially it will be an absolute contraindication, but slowly, as soon as your learning curve will improve, then it will not be absolute contraindication. Uncertainties regarding diagnosis. If you're not sure that what I'm thinking is basically this is the nerve which is causing pain and I'm not sure, we don't give this block. Uncooperative patient, definitely if patient is have cognitive behavioral disorders or patient is not psychologically well, I think we cannot just give. These are the, according to me, is our absolute contraindication. Relative contraindication, definitely if patient is neutropenic and receiving chemotherapy or some kind of a neurological deficit. If patient is having neurological deficit, I have kept in the absolute contraindication. If you think that this kind, for example, an epidural or a spinal block will give patient good pain relief and life expectancy is in weeks or months, and if pain is not relieved otherwise, definitely we should try, but it will come under relative contraindication. If there is neurological deficit, we should think twice before giving block. So there is a way that we have to balance the intervention versus pharmacotherapy. Now what you will do when you will plan intervention, this is the most important slide, which I think even at any stage when we plan and when we try to integrate interventional procedure techniques in your day-to-day practice, then this is a most important slide for everyone, that before doing procedure, it is very important to do good assessment, because most of the time failure happens because of inadequate assessment. So always remember that whether you are doing pharmacotherapy or you are doing intervention, inadequate assessment of pain will lead to inadequate pain management, and then you will feel disappointed that my technique is wrong. Because your assessment is not good, then you will feel you will not be a success. It will not be a success. So what are the assessment we should do? The detailed history, meticulous physical examination, underlying coagulopathy, informed consent, simultaneous confidence building. Because every procedure, because most of the time in cancer patient, if you are doing some kind of intervention and patients are apprehensive in various stages, whether it's a diagnostic or during the treatment or in the last stage, they are apprehensive. You have to build a confidence. It is not only the cancer patient, otherwise also we should have a habit of building confidence. What we are doing should be explained to the patient, and there should be a, you should, both of you should be on the same page, that what you are thinking about the procedure, same thing patient is also thinking. Give the realistic hope. Always, it is not a miracle, because unrealistic hope immediately will happen, especially in private center. If you will do some procedure and it is very expensive, and patient, otherwise also, if you are a very renowned pain physician and if you are giving a block, patient will start thinking that my pain will be immediately relieved. But if you think that pain will not be relieved completely because it's a diffuse pain, or whatever I'm doing is just to decrease the intensity of pain, please give the realistic hope to the patient. Otherwise, unrealistic hope will lead to again unsuccessful block, and there will be no confidence between you and patient. Explanation of side effects. Most of the time we do procedure, but we forget to explain, because every procedure in medical science has got some or the other kind of side effects. If you will not explain it, you will not be again a successful pain physician. So this is a very, very important slide. Pre-procedural assessment is very important. Then once you have assessed properly, you have successfully assessed, then there will be a second thing, will be planning the procedure. Planning the procedure will reassure and reassess the emotional and psychological status of patient, because again it will lead to unsuccessful block otherwise. Expectation of the patient, what my patient is expecting. Maximize comfort for operator and patient. It is not that patient should be comfortable, you also should be comfortable whenever you are giving any kind of intervention. Gain IV access and maintain asepsis, because even if wherever you are giving block, whether in the district hospital or in the village or in the bedside or in the operation theater, asepsis, maintaining asepsis is very important. Radiologist should be standby in cases of difficult or distorted anatomy. In case you are doing ultrasound guided blocks, withhold analgesics prior to procedure for better appreciation. For example, if you are giving a block for intercostal block and you want to see proper that whether my diagnostic block is successful, please withhold analgesics for some time till the time, because you are diagnostic block, you are giving local anesthetic which is going to act immediately, and patient will get good pain relief, and you will be 100% sure that my block has worked. If patient is already on analgesics, you will not be able to appreciate. And then if at all you fail, then we should have an alternative modality in our hand, because this is also our responsibility. In case I fail, what should I do? So this is one of our resident, I think very old, 10 or 15 years old. She's Preni. She is assuring and counseling the patient that what exactly we are planning to do. So give assurance, sedation and positioning. What is best practice in intervention? Reassess the need of intervention, because again, whether what I'm doing is really required. So this is again, make it a habit that you have planned intervention, for example, maxillary or mandibular block. Again, before giving intervention, again think that whether it's really required. Pre-procedural screening is very important. Giving diagnostic block is a good habit. Make sure that whenever you are giving your starting practice, please give diagnostic block first. So give diagnostic block will give you confidence, will develop confidence between you and patient that this technique is going to work, and it is going to be short acting. So if at all there is any complication, it will happen only for a short time. So giving diagnostic block is a important practice and which we should follow. Avoid overzealous approach and procedural overturn, especially for novice. This means beginners, if you have a, for example, in the survey we have seen that many people have done observation and they have done training. So it is definitely they have done training because they want to start. But if you are not very confident, please don't do over enthusiastic approach. And because over enthusiastic is a good Hona is a good this thing that we should be over enthusiastic. But if we are not sure that I may cause some kind of harm to my patient, please call for help. Always there is someone to begin with, and if you are not very sure about the procedure, there are people, those who understand, and in the beginning for a month you will need help. Help does not mean that you are going to, this person is going to do the procedure, but definitely he is an experienced person, and in front of him you are doing the procedure, and whether you are conducting some kind of a deficiency is there, he will definitely tell you. So there should not be overzealous approach, or we should not harm patient by incomplete knowledge, and we should have a habit that calling for help in case we are in trouble. So again, this slide was, I think, made by one of my resident for me. I think this slide was made by, I don't know whether Saurabh has made this slide, that if you really want to become a pain physician, you will have to open your third eye. Third eye means we have to go inside and do some kind of a block. So to become a good pain physician, third eye, what are our third eye? When I was doing my MD, we used to give blocks, and our blocks was only based on surface anatomy. I have never used anything. My teachers used to explain me that it's giving superior supraclavicular block or infraclavicular block. We used to use only surface anatomy, and we used to be very successful also most of the time. So injection based anatomy and surface based anatomy, we used to have a real third eye of ours. Then came the fluoroscopy. Fluoroscopy people are using, and it is becoming third eye of pain physician. Then CT scan is a very important modality, which is also people use as a third eye, pain physician use as a third eye. Then MRI and PET scan again. But fluoroscopy, CT scan and MRI, all these modalities is not very easy to procure. To start with, for CT you need a CT suite. For MRI and PET scan, the suite should be empty, or the patient vacated and patient should go there. So all these things are practically not possible. So then it came the ultrasound. So understanding ultrasound, bedside ultrasound or bedside anatomy is a norm in these days. If you really want to start your pain practice, you should know how to do ultrasound guided peripheral null block and central block. So ultrasound has become a very good third eye, like in a stethoscope. What we used to do for listening murmurs and all. In these days, ultrasound has become a best third eye of pain physician. Now this is a photograph of our pain room, pain clinic and procedure room, and I have jumbled up everything. I have jumbled up everything for you just to show you that these are the equipments which we should have in when we start interventional pain management. Ultrasound, C-arm, Scrambler therapy machine, radio frequency ablation. But I say that it is not an important thing which we should think on beginning. If you want to start interventional pain procedure, and if you will ask all these things, you will never get it, and you will never be able to start. So what exactly we should do? We should have an attitude that I want to start pain intervention in my practice, and now I will come to you that how you will start. So forget about this slide. This has come over a period of 20 years. So it will take time to procure all these things. The first thing, you should have an attitude, and you should have a practice that's for simple. Even if I will give simple block, I will be knowing the procedure well, because for giving peripheral nerve block, you don't need all these equipments. Even if ultrasound knowledge, simple ultrasound knowledge is enough. If it is not there, then surface-based anatomy you can start. But you should not forget that keeping a patient is building confidence and taking sterile precaution is most important. Then this is very important when I have seen people give blocks, but they forget to keep all these equipments for monitoring suction and supplemental oxygen, because even if you are giving a lignocaine or bupivacaine, patient can have deleterious side effects, and patient can collapse and whatever can happen. So you should have all these equipments for monitoring and for resuscitation ready. It is not a big thing because every PHC, every district hospital, all these equipments are available. Ambubeg, tube, noradrenaline, atropine, all these things are very, very simple things. So with these things, with your attitude, with correct practice, you can start giving simple nerve blocks. Now, the question comes that it's a huge human body and it's a complex human body. What can I give and what I cannot give? So this is just a broad picture I have brought. In 2 slides, I will explain that what are the different blocks which you can immediately start in your day-to-day practice. Immediately, you can start peripheral nerve blocks. For example, mandibular block, maxillary block, glossopharyngeal block for carcinoma tongue and head and neck cancer patients, stellate ganglion block for the patient, those who are having pain in this thing. Then we can have we all know because of the central neural axial block, epidural and intrathecal. Because of we all know that there were receptors in the spinal cord, throughout this receptors are there, and in 1970s this has started, and it has given good relief, and since ages anesthetists are giving spinal and epidural, and this is the best methodology of pain relief. Similarly, we can definitely spinal and epidural we can definitely adopt immediately in our day-to-day practice. When you will give spinal and epidural, it will all depend on the patient's life expectancy, that spinal epidural is a good modality, but what exactly whether you want to give spinal or intrathecal, you want to put catheter, or you want to give percutaneous epidural catheter, or you want to use intrathecal drug delivery system, it will all depends on life expectancy of a patient. For example, if life expectancy of a patient is few weeks to few months, then we can just get away with the percutaneous epidural catheter or intrathecal catheter, subcutaneous catheter. But if you think that my patient is a cancer survivor and but she or he is in severe pain and may survive for years together, then definitely we can use intrathecal drug delivery system. Then comes the sympathetic block, famous celiac plexus, hypogastric plexus, and ganglion impulse block. So we all know that okay, so this was the slide I have already mentioned. We all know that since ages we are talking that for upper abdominal block, for celiac we can give celiac plexus block, and for lower abdominal we can give hypogastric, and these slides will come with you, reach to you, and you can see that wherever there is a pain, what exactly which area the painful is and what block I will use. So celiac plexus, hypogastric plexus, and then next comes the ganglion impulse block is a useful modality in cases of patients with CA anal canal, carcinoma rectum, anal sphincter is having pain. All these patients get very good pain relief with ganglion impulse block, because if you are with medication like morphine or any medication will increase pharmacotherapy or increase medication analgesics, these patients will develop constipation, and once this constipation will develop, their pain will aggravate. So we on one hand we are treating the pain, but because tumor is there, because there is some kind of a pathology in the sphincter, patient will have severe pain, and this kind of blocks is good for these patients. So learning these simple blocks is important for all these patients. So I have written everything. So in these 2 slides, what are the blocks which you can give, and I am not going to go into the details of all these blocks, but definitely these are the only blocks which cancer patient needs. Brachial plexus block, if a patient is having brachial plexopathy because of radiotherapy, because of chemotherapy, or the tumor has encapsulated and brachial plexus is involved, nothing will work. You keep giving medication, patient will either sleep or patient will weep. And giving brachial plexus block will give dramatic relief. So all these blocks are simple. Just make a list of all these blocks and start doing one by one in your practice. Now we come to the this is just a photograph of intrathecal drug delivery system. This patient is still alive. Can you believe it? 10 years are over. We have put because this patient was having phantom limb pain. And I think 6 months back she came. When her implant stopped working, we have to we removed this implant. Otherwise, for 10 years this implant has worked, and she was on 1 milligram of morphine per day. This means she was requiring 300 milligram of morphine, oral morphine per day. So rather than giving, imagine, she says that with this one limb she used to work, she was cooking, she was washing clothes, she was doing all household activity, and she is still very active, very pleasant patient. So this is the way we can improve. And yesterday I have seen one of a very good article that intrathecal drug delivery system has got good evidence that if in a right selected patient, it gives good quality of life, and sometimes quantity of life this patient is disease free. So we are not bothered about quantity of life. Whatever she will have life, she will live. But she was in severe pain and she used to take 300 milligram of morphine, and for 10 years she was on 1 milligram system, and she was doing very well. So this is another kind of patient. Whenever you find the kind of a patient with multiple myeloma or prostate patient, when you think that these patients are having vertebral collapse, and this patient is for vertebral collapse of this kind, you keep giving medication, patient will not be able to get up from bed. Morphine will make him sedated, analgesics like NSAIDs will give severe gastritis, but patient will not get pain relief because the vertebra is collapsed, nose is compressed, and patient is having severe pain. So this kind of a procedure like vertebroplasty and kyphoplasty, I am not saying that you should start. I will tell you what are the solution of all these things. I'll come back to the slides. But definitely, please give an option for these kind of a procedure in these patients. This is just a one slide which I have brought for 24 months audit of 2082 patients in our palliative care ward, where we have done so many procedures. So you can see, I will not go into the detail, but all procedures we have conducted. Only 29% of our patients required some kind of intervention. Rest all patients were on oral pharmacotherapy. These 29 includes early intervention as well as throughout the disease. So total 29%, we should work hard to give quality of life to the patient as best as possible. If you think that pharmacotherapy is not going to work, if you think that pharmacotherapy is working but giving intolerable side effects, please opt for intervention, and this kind of intervention you will need only in 29% of patients. Now, when we go to the literature, even the Vanchikanti has said in 2010 that there is huge paucity of evidence in terms of cancer patients. Because of paucity of evidence, nobody has made clear conclusion that what exactly we should do in area of intervention in cancer pain patients. So he is narrated for very, very important points why there is so much of scarcity of evidence in area of cancer pain patients. So because first important point which we all agree that large well-defined RCTs are difficult to conduct. The patient is in severe pain, the patient is in the advanced stage of disease. We want to give pain relief as early as possible by all means, whether IV, morphine, or intravenous fentanyl or PAD, or whatever. So it is always very, very difficult to do a randomized controlled trial in cases of cancer pain patients. The issue of ethics, feasibility, cost, and reliability. Again, ethics is many times ethics you will not get clearance. Feasibility is a problem. cost is a problem in cases of private hospitals or corporate hospitals, and reliability, because sometimes patient will not get relief at all because of the. So this is the second problem. Third, very important, which is exclusion of well-designed observational study from guidelines and policies. Whatever guidelines in cancer pain management in terms of in area of intervention is made, it is a practice that we exclude observational studies. And most of the time people are doing observational studies because they are not getting good support and they are not getting ethical clearance of doing randomized control trial. And then finally he has said that is very, very important, we must learn this from this fourth point, that various other biases for or against organizations, entity, individuals or technique. हम लोग क्या करते हैं that we are not very, very confident of a colleague who is having good knowledge in intervention. So we are not referring this patient in time. So there is a bias in our mind. We have to change our attitude. The famous physician of the world, he has narrated is absolutely well that why there are so much of lack of evidence. Now I will come to the evidence. Whatever evidence I have got in last 3 weeks, which I will come to the this evidence. So most of the time, I think I should be proud of this, that most of the evidence in interventional pain in cancer patients I found in Google when we do is our articles I found. So this is just an article which says that integrated pain and palliative care medicine model, which Mayank and I have written. And what is the conclusion of this article, that advantage of integrating pain and palliative care? What is the advantage? That early and efficient pain control in conjunction with palliative care leads to better outcome of curative therapy and increased survival. Means when we will integrate, outcome will be better because quality of life will be better and some kind of survival will also improve. Second point, advantage is optimal pain management at all stages. I am not saying at advanced stage, in the early stage, in middle stage and in advanced stage. All stage in terminal patients will allow patient to live as actively as possible. Giving a block, if patient can move till the toilet and you think that he is unable to go to the toilet, and by giving this femoral nerve block or some kind of a caudal block will allow my patient to do his daily activity, is much better than not giving this. So including or integrating pain and palliative care is most important. This is again a slide which I want to say, that this is by integrating pain, the purpose of bringing this data from 2013 to 2018, our data is that by increasing, although they see the number of patients are increasing, but morphine consumption is decreasing, because by integrating intervention, definitely we will decrease opioid consumption and improves quality of life of our patient. Then this was I have presented in Singapore that in 2011, that by giving maxillary and mandibular nerve block, this was the best paper they have selected. Out of five best paper they have selected, although I have not got the award, but they selected and I gave oral presentation. That time I used to go and give put posters and give oral presentation. In 2011 I went to this oral oncology conference, and the paper says that radio frequency ablation for intractable pain in cases of head and neck cancer and cancer base of tongue with glossopharyngeal nerve improves and decreases the opioid consumption. And this photograph we see day in day out in cases of lung cancer, when there is a single rib metastasis because of carcinoma breast. And we have published this paper in American Journal of Hospice and Palliative Care, and Arif took the lead in this data, that again ultrasound guided radio frequency ablation by giving intercostal block prevents incidental pain. Incidental pain in cases of intercostal, in cases of metastasis is severe. Patient is pain relief when he is not doing anything, but as soon as he is taking deep breath or he is laughing or he is doing any activity, suddenly the pain increases. So incidental pain can be reduced by doing intercostal radio frequency ablation. Then in 2011, simultaneously, we started looking for ultrasound. That ultimately ultrasound was in our medical oncology department, but we borrowed ultrasound and we started doing ultrasound guided block. And first article which we have written in Journal of Palliative Medicine, it is a, once we have realized that this is a boon in for palliative care physicians, and we immediately wrote an article that ultrasound, bedside ultrasound, a radiological boon for placement of nerve block for abdominal malignancy. Then we started giving blocks, and first paper which we have written in and published in Pain Physician is gastrointestinal malignancy, neurolysis for gastrointestinal and pelvic malignancy. What we have given evidence that this works very well. Again, it decreases opioid consumption, improves quality of life. And then this was not a very relevant, but we did a randomized control trial, because at least this much everybody is knowing who is listening, that usually celiac plexus block we give by 2 needles. But what we have realized by doing ultrasound, that when we used to give with single needle, the drug used to spread very well both the sides. So we have done an again an RCT and bilateral versus single needle, and what we have found that single puncture is enough for the patient, and there is no need to give double puncture. Then this was again a block for hypogastric, superior hypogastric plexus block, which again ultrasound guided for pelvic malignancy, and what we have found that decreases opioid consumption, improves quality of life, and was at the end patient was very happy. Then finally, because all these studies were not in the guidelines, so I thought that we should give some better evidence to all these people. So I talked to Dr. Tulkar that when we are giving ultrasound guided block, can we inject some kind of a dye and see the CT in the CT that whether dye is spreading. So we did, although there were only 14 patients completed this study, but what we have found is when we give ultrasound guided block and dye is injecting, we are injecting the drug is spreading like this. So it was a successful block, although successful block, but we could see only through CT that dye is spreading very well, and we have published this in Indian Journal of Gastroenterology. Then I tell you this photograph first, and then I will tell you about this. This lady is still, again, this lady is alive, almost, I think it is 15 years old. She is and she used to have a post-thoracotomy scar pain. So whenever she used to come to our clinic, we started morphine, fentanyl, gabapentin, pregabalin, n number of drugs we have started, but she used to either sleep or she used to weep. She was in severe pain. So we did peripheral nerve field stimulation for this lady. Peripheral nerve field stimulation, I will not go into the detail, but this is a technique which works basically on the principle of TENS, and there will be a firing, and whatever the impulses will go, pain will be, she will perceive as a pleasant sensation. So we did peripheral nerve field stimulation, and again this lady is still surviving and she is having good pain relief. This patient was a patient of a cervical plexus neuroma. Dr. Dev has removed the neuroma, but he was having severe pain, and he was a driver by profession. So whenever he used to wear belt, he used to have severe pain. And so, but again, we gave all these medication, and his boss was an IAS officer, and he used to call me that most of the time he's sleeping because of your medication. So we tried peripheral nerve field stimulation for this patient, and again, he got a very good pain relief. I am not saying that all these intrathecal drug delivery system, peripheral nerve field stimulation, all these are day-to-day practice. But total implant in last 21 years we have given is 20, and peripheral nerve field stimulator we have put is only 6. But these are in a selective group of patient. Imagine this patient, if we would have not done this, she would have cried till now, and she would have died by this time. So all these patients, we can give good quality of life, and give if you think that this patient falls in this category, please take help of interventional pain physician. Without a non-pharmacological therapy, we have now created ample evidence of Scrambler therapy, again, which works on the principle of TENS, and in basically chemotherapy-induced neuralgia or neuralgia, but he's disease-free, like myeloma, and those patients, because of chemotherapy, neuralgia, they keep on having some kind of tingling numbness, and they cannot even move, they cannot even build chapels. So all these patients get good pain relief with TENS, that works on principle of TENS Scrambler therapy. I will. This is an article which everybody should read. This Komal is my PhD student. I told her when she finished her PhD that please write a whole history of Scrambler therapy. Whatever has happened in the world, please write a review article. And I am really proud of her that she has written a review article and published in Pain Physician. And if you will read this article, you will find the whole history of Scrambler therapy, what has happened, from where it has started, and how much it is giving, how much it is useful in day-to-day practice. I am not saying that if you don't have a Scrambler therapy machine, you will not be able to. This also gives an indication that simple TENS machine, which comes less than 1,000 rupees, I think, or less than 2,000 rupees, if we will offer simple TENS to a patient, those who are having severe chemotherapy-induced neuralgia, I think this will be a useful thing. She had a randomized controlled trial in her thesis, and it has also been published and is going to be published in 23rd of March. It has come online and it will be published in this coming issue. Randomized controlled trial on Scrambler therapy. On one arm, she has given only medication, and she's seen the course. She used to see the quality relief. On one arm, she used to give Scrambler therapy with medication, and she used to see the quality of life. And third paper is in review under primary medicine, that how quality of life has improved with simple technique of Scrambler therapy. There are other evidence which this I have seen in Journal of Clinical Oncology, that this was a randomized controlled trial, and they wanted to say that early endoscopic ultrasound guided plexus block definitely prevent pain progression and again improves quality of life, and they clearly say that morphine consumption decreases drastically in early this time. This was again a very good paper which I have which was published in Pain, that effect of early or late neurolytic sympathetic block on the management of abdominal and pelvic cancer. They have made 3 groups, and one group they used to give normal medication. In one group they used to give only blocks, and in third group they used to do combined blocks as well as medication. And what they found, the third group in which they used to give block and as well as medication, there has to be a balance, and it will come only by experience. And this was again our paper on early ultrasound guided block, and this is again an observational study. And what we have found, that by giving, as soon as it has been diagnosed, giving celiac plexus block improves quality, improves pain relief, and hardly any patients require opioid analgesics. So finally, what should be your base practice? After seeing all these investigations, what exactly you should do? Now 2 more slides and then I'll stop. That we should reassess the need of intervention. I'm again going on to the older this thing. We should have a pre-procedural screening, that my patient is requiring intervention, whether you do through ultrasound or any other method, by seeing CT films, whatever way. You always should have a habit of giving diagnostic block first. You should not have an overzealous approach. You should not do harm. I am repeating that slide because this is an important slide. By incomplete knowledge, always don't make it a habit. Change your attitude. You should not have any egos. If you really want to help your patient, you should call for help. We should not think that procedure is over. I have given good block, patient is pain relief. We should have a post-procedural follow-up. Be aware of the reason, specific complication, what block you have given, what complication patient can have. Early diagnosis and treatment is most important. Early diagnosis and treatment of post-procedural side effect, I'm telling you. Reassess pain relief and reassure you. If side effects happens, reassess pain relief and reassure your patient. Barriers will come. Now everybody will think that we have so many barriers, and how we will start, whosoever is listening. Barriers are going to come because it is a life where every day there is one barrier. Life will not be interesting if you will not have barriers. So we have to handle barriers, and we should know how to handle barriers. So my recommendation, this is my last slide. that must try to define overlapping roles between pain physicians and palliative care physicians. According to me, a good palliative care physician has enough work. So we should have a good, our entity is will be that we are doing good palliative care for our patients. But if a good pain physician has become only the block technician, I call now block technician. If a pain physician is giving only blocks and not considering palliative care physician or a patient as a human being, I call them a block technician. So there should not be in too extreme. We should have a clear cut, because a patient is one and there is going to be overlapping role. You have to sit down in, if you are in your institute, if there is a pain physician and you are a palliative physician, please sit down together and see that how can you make a team together, rather than doing this that, oh no, I will not send the patient is good in the end, or pain physician will never send a patient even if patient is dying because of because he is not getting morphine. So this should not happen. You should make a team sitting together without any egos. Changing your attitude will definitely guide and govern you. Patient care will be benefited by close interface between pain and palliative care. Every patient will definitely get benefited by together with pain physician and palliative care physician. Try to get evidence, even if you are doing a single block. For example, if you are started with maxillary block, please try to create evidence that whatever you are doing is neatly, cleanly, transparent, and you are going to publish it, because without publication you don't have it does not have any value. Interdisciplinary pain round you must start immediately. Whenever you are going for a round, if a palliative care physician and pain physician will go together, it will make a huge difference and the decision will be there, and that there only you will be able to make decision. Hospital based pain and palliative care policy, although many people must be having palliative care policy, but you should also integrate interventional pain policy, that my patient should not be deprived of interventional pain procedure if they need. Routine bedside teaching is an important aspect and we must not forget. Dedicated teaching and training to use bedside ultrasound, it is ultimately need of the hour. UGPG curriculum, you must start teaching your PGs about this, and compulsory rotation of PGs in pain and palliative care services in your hospital. If your administrator are not missing, you should go and emphasize that this is important. Please do not forget that training of judicious use of opioids are important. These two children, they cannot by any kind of intervention. You have to have a good knowledge of using opioids. So you have to balance your knowledge and your mind. There are two compartments. One is having full of knowledge of pharmacotherapy, one is having full acclimatization and sensitization of intervention, and how can I, but whenever there is a need of judicious use of opioids, you should have a good knowledge of opioids. And this is my last slide, that when you will give pain relief by making all your efforts, patient will definitely bless you and you will be able to do whatever in the world is possible. Thank you very much.
Thank you, ma'am. It was really mesmerizing and a very interesting presentation. We have a lot of questions here.
Okay.
I'll start with a few important ones, like should a poor performance status patients be accepted for interventions?
So poor performance status patient should be accepted for intervention if you are very confident this kind of intervention will work. For example, I give you a patient is having severe neurotic pain because of some kind of a tumor in the spinal cord, and patient is severely having pain, and patient is, we think that life expectancy is weeks or months. Definitely giving spinal any central spinal blockage we must give. Definitely in aware again overzealous approach nahi honi chahiye. So if you think that patient is too bad in a condition that this block is not going to help and I'm not confident, please don't give. But if you are confident, definitely we can give.
Thank you, ma'am. Ma'am, what is the scope of palliative care physicians to do intervention pain training, and how do we go about it? I think everybody has that.
See, the pure palliative care physician, I will say that you should have a basic knowledge of pain intervention, that when my patient will be requiring intervention and when should I send my patient for intervention. I am not saying that you should have a full knowledge and you should start doing intervention. If possible, start doing. But in any hospital, I can see that any of the hospital in the world, pain physicians are there. If they are there, please make them as a team. If they are not there, start learning. If there is no pain physician in your center or in your hospital, you start doing. But if there are pain physician, don't become a competitor. You should complement each other. Make him a team. You should have basic knowledge. If you will not have knowledge, you will not be able to refer the patient. You will not be able to offer the patient any intervention. So palliative care physician must learn basic pain management techniques or interventional knowledge they should have.
So, ma'am, there is one more question related to the same thing. What are the basic procedures that a palliative care physician can do in a PHC for intervention pain?
In the PHC, I think simple nerve blocks. I will give you this photograph. I will come back. Simple nerve blocks we can start immediately. This is a very good photograph. I think my resident Karthik took this photograph for me, that definitely a CFL patient, base of patient is not having good pain relief, loss axillary mandibular block, they can start. If a patient with carcinoma breast patient comes and having the brachial plexus is severely met with the disease and patient is having severe neuropathic pain in all over the arm, definitely this is a simple block which you can start. Intercostal block you can start with ultrasound. I will not advise in PSCs about celiac and splanchnic nerve block because they have associated complication. Don't start this. Epidural and spinal, definitely. If patient is having severe neuropathic pain and you think that patient will not survive for more than a week and patient is screaming in pain, definitely you should do even till the neurolysis. So subarachnoid alcohol also the only thing. We should have a clear cut listing. The patient is in severe pain and having life expectancy, minimum life expectancy, and I can relieve it by doing spinal neurolysis.
Yes, ma'am. And there is one more question which is related. That is, if the plexus itself is infiltrated and the anatomy is distorted because of tumor infiltrating the plexus, should we go ahead with block?
So I give this example. What we do that if this plexus is infiltrated and patient is having severe pain and not getting relieved by any medication, what we do, we inject. Please see to the ultrasound. I think we should be very, very confident. We call our radiologist. Wherever we see any nerve, we inject the medication. So, whatever medication you will injecting, it will spread. But I will not advise without any supervision we should do this. If a plexus is if the whole plexus is diseased, definitely there should be a supervision and you can inject the drug and drug will local anesthetic and will spread and patient will get good pain.
I think that answers the question. What all medication should be used for a long duration block, and is there a protocol for repeating blocks?
So a long duration block, for example, we come to the celiac plexus and splanchnic and hypogastric plexus block. So celiac plexus block, again, I told you in the first slide that life expectancy will govern what exactly you are doing. So in celiac plexus block, we will give diagnostic block with local anesthetics. And once we are sure that patient is getting good pain relief, then we will do neurolysis. And in neurolysis, we phenol. So alcohol is 100% alcohol. We will use with the, for example, 10 ml of 100% alcohol and 10 ml of bupivacaine will make alcohol 50% and bupivacaine will be 0.25%. So this will get, we will get 20 ml of drug and 50% alcohol, and half strength of alcohol and phenol will give pain relief for this patient for 4 to 6 months. So this is, and then if you think that patient is going to last long, is disease free, then we can use intrathecal drug delivery system or a spinal cord stimulator or something like
that. Ma'am, there is a basic question on consent about doing blocks. So can the consent be taken from the caregiver if the patient is cognitively not well? or
so cognitively not well is a contraindicated by. If patient is cognitively not well, I don't think that we should try intervention, and best is that we should not do intervention.
I think that answers it very clearly. Ma'am, there are some certain questions on what are the blocks that can be done in OPD basis.
I think I have answered this. The mandibular, maxillary, they are our daycare blocks. We give block and we send the patient home. Mandibular, maxillary, even the scalp block we give. Intercostal block is a daycare block. All blocks are daycare except we keep planting the block only for a day because they have got associated side effects. Patient, as soon as the sympathetic will be blocked, patient may get hypotension and diarrhea. So we give them a day and then we send them home. And in cases of intrathecal drug will not, we keep patient for 2 or 3 days. Otherwise, we can do as a daycare procedure.
Ma'am, this is question from me, that is, how early can we consider blocks in a patient having pain?
So, Anuja, as early as possible. If you think that pain is of single dermatome, even if pain is diffuse, but the major pain is from a limited dermatome, definitely as early as possible. You will get a good pain relief to the patient, and you will have to. Many of our patients, they don't go on opioids, and then only paracetamol is enough. And as well as patient is having breakthrough pain, definitely in these 3 categories, definitely as early as possible. If patient is having long life expectancy, as I told you, the amputate patient and the patient with thoracotomy scar, I would not like to put the patient on medication. And definitely when intolerance are there, these 5 indications are very, very important. As early as possible, if you think that it is going to be beneficial, you should do that.
Ma'am, last question: is there any? Are there any courses available for training in intervention pain for palliative care physicians?
So there are many courses. In Indian Society of Study of Pain has started fellowship. The Calcutta, you go and you can. There are many courses. I think that course you will have just an idea that what exactly we can do. Again, you will have to create your own system. I'm telling you, you have to create your own system. Small steps will be enough. Start with the small steps. Start with the small blocks under supervision, and then you will find a day within a year when you will start doing yourself. When you will start selecting your patient yourself. In pain courses, you will not learn how to select a patient, how to give confidence to a patient, how to select a patient who is having very, very disturbed in a cancer patient, especially because of the extreme of disease or because of advanced disease. You are a palliative care physician. You know how to handle my patient, how to select, how to assess pain. Observe from all these courses. Start doing with the small blocks with the pain physician. If you have in your system, involve him in your team, because both of you are required for each other. So it is not that alone pain physician can do anything. Otherwise, he will become a block technician, I told you, or alone palliative care physician also will not be able to do anything. So together you can make a difference. Start alone in your own setup. Start together in your own setup, and you will see that after a year you have developed a very good interventional pain services in your setup.
Thank you, ma'am. It was really a wonderful presentation, ma'am. I think we have a good learning from your session that teamwork is the key, and we have to work together with pain physician as a team. So I think, ma'am, we have covered all the questions. Thank you for the excellent presentation.
Thank you very much, Anuja, Nisha, again, and see you all on next Monday, 6:30. Naveen, thank you very much for introducing so nicely. This has given me it's given me a boost that I should talk now. So thank you, Naveen.
Yeah, thank you, madam, for an excellent presentation.
Thank you, everyone, all seniors and all juniors, those who are listening. Don't get disheartened. You can start. Only thing, you should have an attitude. You should be brave enough and start one day. And after a year, you will find that your hospital have a good integrated pain and palliative care services. Thank you very much.